So good morning, everyone. I'd like to call the meeting to order. My name is Michael Fiorelli, and I'd like to welcome our task force members to the second meeting, and all of the guests at Nationwide Children's Hospital, welcome. The hospital is pleased to host this very important continuation of a conversation today. We had a very successful kickoff on January 31st, so here we move into meeting number 2. That meeting also had some great media coverage, as I'm sure many of you noticed. We're already starting to build a greater awareness of the issue of infant mortality in this community, so our work is well underway. That awareness is certainly the first step in arresting this horrible problem that we're dealing with. Also, as many of you saw in the news yesterday, there's been some great coverage at the state level. 2 state senators unveiled a package of 5 bills to deal with infants' lives, co-sponsored by Senators Tavares and Jones. So we're happy to see that things over in the State House are also starting to happen. So as you recall, the intention of our last meeting was to agree to our process as well as to understand the local data and the challenge ahead of us. The task force should have received notes and minutes, a summary of that meeting, and we've also posted the summary on the website, which if you haven't been there, you ought to take a look at it. They've really done a great job with this website. Everything that gets covered in these meetings ends up on the website and more. As we get started today, I want to remind everyone that our time together is short. These agendas are going to be tight, and for that reason, again, we will be unable, although we welcome guests, we'll be unable to accommodate questions from guests who join us, but we are implementing several processes that will allow us to hear voices from everyone in the community, including workshops with various stakeholder groups as time goes on. The first one of those will be February 21st with the subcommittee of the Community Health Collaborative, which is a city-county partnership who's working to better coordinate efforts, and the details about that meeting will also be on the website. We'll be scheduling presentations to various community groups as this effort moves forward. Those meetings as well will be on the website, so pay attention to the website as these meetings get scheduled. If any of our guests have suggestions or ideas, there are cards in the back of the room on the table. Fill them out, get them to us, email us. Our email addresses are on the website also. We're glad you're here. We welcome you at all of these meetings, and we look forward to hearing from you along those lines. So Don and I decided we'd start each meeting with a look at our key driver diagram as a reminder. So we're going to start with that. We've organized our work to focus on those areas where we believe that we can move the needle to make sustainable change. Somebody's going to put it up there pretty soon.
I could do little.
Okay, we have a driver.
Well, not really. I was not hired for my technical skills.
Yes, that's okay. You're going to get paid anyway.
Well, I'm going to continue, and we'll get it up there in order to keep the trains on time here. Today, we have a very interesting meeting. We're going to talk about the groundwork necessary to reduce,
It's up there.
there it is, to reduce disparities, which we can see cuts across all drivers of infant deaths. We saw some very remarkable statistics last week regarding the differences throughout this community. When Council President Ginther launched this work last November, he was clear that we needed to think about this problem comprehensively. We need to think beyond clinical interventions, and when we think about all the aspects of infant mortality, it touches so many areas that it's important to be totally comprehensive in our approach. And if we're going to reduce the disparities that we saw, we need to think about race. And in particular, one of the graphics that's stuck with me, not only from that first meeting, but in our discussions prior to that meeting, is this one in front of you from Dr. James' presentation, showing the black infant mortality rates versus all the others. If you look at this slide and you think about our goals, which every expert told us at the last meeting are the most aggressive in the country, it is necessarily aggressive because this is startling. I can't think of another word other than startling. Even if we achieve the most aggressive reduction in black infant mortality attempted anywhere in the nation, we will still not be giving black babies in our community an equal chance to survive as all the other babies. Keep this in mind as we go through this morning's session. We are so appreciative of Council President Ginther's commitment and leadership and direction on this issue. His presence here today illustrates that commitment, and I thought, Council President, maybe you'd like to offer a word or two.
Thank you, Michael, and thank you for, again, joining us here today on our journey together to realize a better and brighter future for our youngest citizens. Dr. James and Pat Gabby are here with us. I know most of you know them well. I'd ask Dr. James and Dr. Gabby to stand. Thank you all for being here this morning, for everything that you have helped to lead and guide this process. I wanted them to be recognized. There they are. Thank you. There's not a better term for these two stars of the community for me to recognize them as our experts in residence for this task force. So if there are questions, resources, things that maybe you don't want to raise or talk about in a public meeting or public forum like this, they stand ready, willing, and able to lend their expertise to help fill in the blanks or guide to different resources as we continue on our journey. And feel free to contact the staff or the task force, either Julie or Jesse, to help make that connection. So our work today begins one of the tougher discussions that we're going to have as a group. We're going to look at broader social and economic factors that influence and contribute to infant mortality and the racial disparity rate that Michael mentioned throughout our community. While these issues are some of the most difficult ones for us to tackle, we must understand and confront them as if we are to have any hope of reducing infant mortality in Columbus. As Michael mentioned, there is no way that we can realize our goals and dreams and the commitments that we've made to this community to reduce infant mortality rates by 40% and cut the racial disparity in half without reducing infant mortality rates across the board, but particularly with African American children. So to get us started, we're pleased to welcome Dr. Veronica Gunn. Dr. Gunn currently serves as the Vice President of Population Health Management and Payment Innovation at the Children's Hospital of Wisconsin. She brings significant expertise in care coordination and public health for children. She served as the Chief Medical Officer for the Tennessee Department of Health. Prior to that, she served as Medical Director for the Tennessee Governor's Office of Children's Care Coordination. In 2009, Dr. Gunn was named the Nashville Business Journal Woman of Influence in Public Policy. She also received the 2006 Project Blossom Award for efforts to reduce infant mortality. Please join me in welcoming Dr. Gunn.
I am now a Wisconsinite and I have the
privilege of working with another fine children's hospital in Wisconsin. And so if time permits, I will share some experience from Milwaukee as well, but we're going to highlight these areas today. Let me know if that feedback is too annoying, and we'll switch to the podium mic, okay? So we're going to go quickly over overview of trends, speak specifically to a life course perspective as it pertains to poor birth outcomes, and then I'll share with you some community-based approaches to improving poor birth outcomes, and specifically talk about some critical success factors. I think it's important to understand from where we've come for some context. While we certainly have a long road to go ahead, we have improved dramatically in the nation on birth outcomes in the United States. This is a look at infant mortality rates from 1915 to 1997 across the United States. And you'll see back in 1915, 100 live-born babies, 100 out of every 1,000 died before their first birthday. That is remarkable. And look, over the course of those subsequent decades, we were able, from a variety of reasons, to be able to reduce those poor outcomes. Introduction of a national birth registry, the March of Dimes, Social Security, the introduction of antibiotics, and injury prevention strategies, including child safety seats, all had a tremendous impact on reducing poor birth outcomes. If you were to continue this line, though, for the next several years, for most cities and most states, it plateaued. And that was our experience as well in Tennessee. So this is infant mortality rate by race in Tennessee for 1999 through 2006. You can see that that line remained fairly stable in that period of time, and you can see at the state level that there remained a great disparity in birth outcomes among African Americans and Caucasian populations, similar to the slides that you had just a few moments ago representing Columbus. So it's important to understand why this disparity persists despite the introduction of many important and life-saving interventions. And that's where it's important to have some context around the life course perspective. Now, this model, which was introduced by Michael Liu, and the paper that I reference here is by Neil Halfon as well, it helps us to understand the lifelong influences on birth outcomes. And there are two key factors to point out in this model. The first is understanding that there are critical periods of development over the course of one's life. And during those critical periods of development, exposures and experiences can create lifelong impacts on health outcomes. For example, think about exposures to a developing brain in utero, before a baby is born. And that can have impacts for that child born as a child and later even on as an adult. This has been found in many studies in the United States as well as in Great Britain. Some of the more familiar studies, Dr. Barker, David Barker, from the University of Southampton, describing low birth weight babies having a higher incidence of cardiovascular disease, adult onset diabetes, hypertension, stroke, etc., as adults, etc. The other important factor to consider in the life course perspective, in addition to understanding their critical periods of development, the other is that over time, exposures to experiences, both positive and negative, have impacts on our health. People think of this as weathering. That makes sense. You think about the exterior of your house or car, and in these conditions, it gets weathered. So does our body. So does our life, our health is affected over time by those chronic exposures. So let's keep those two in mind as I walk us through this. On this model, on the x-axis, on the bottom line, is time over a woman's lifespan. On the y-axis, the up and down line, think about that as reproductive potential, the potential to have a healthy pregnancy, a healthy outcome, a healthy lifetime. In this construct, that first line, that top line, Let's imagine a young girl is born that has a supportive environment, supportive and nurturing and family, supportive and nurturing foods, a culture in which there are healthy behaviors, an environment, community in which there are health supporting policies. This increases one's potential over a lifetime. Imagine a second child born, and this represented by that red line, and that during that in uterine experience, before even born, that child is exposed to experiences like maternal stress, maternal behaviors such as smoking, lack of sufficient nutrition, inadequate housing, inadequate social supports. Those stressors, those experiences affect the in-uterine environment, which affect that child's potential such that even at birth, even when that child is born, already there's a difference in that lifelong course. Recognizing again that there are critical periods of development when those stressors happen at those critical times, such as puberty, such as subsequent pregnancy, it can further depress one's potential over the lifespan. Now, I'm seeing some curious faces, a little bit of blank stares. Let me try that again. In general, the life course perspectives encourages us to take into consideration that focusing on mom's health during pregnancy is really important, but it is wholly insufficient to address differences in poor birth outcomes. Pregnancy is one critical facet of development. However, the lifetime of that mom, before she ever becomes pregnant, she carries that into that pregnancy with her. Her well-being, her stress level, her hormones, her body's capacity, which has been affected by her experiences over her lifetime, all of those impact her ability to have a healthy pregnancy. And so in order to address that outcome, that risk, we really have to think about mitigating risks over the entire lifespan and not just during pregnancy. And this is borne out also in the information that you collect as a city, as a county, and as a state. There's a tool called the Perinatal Periods of Risk tool. It allows us to understand poor birth outcomes by categorizing them based on age at death and weight at birth. And I'm going to walk through this very quickly for you. Deaths, when they occur in the fetal period, which is 24 or greater weeks, the neonatal period, which is a live-born infant that dies before the first month, a post-neonatal period, a live-born infant that dies sometimes before the first birthday, but after that first month of age. And then that top line represents very small babies, 500 to 1,499 grams. And the bottom line represents the larger babies, 1,500 grams. Keep in mind, 1,500 grams is 3.3 pounds, so not a big baby, okay? And those categories there are relevant because they give us an idea of how to intervene. Now, did previous speakers address PPOR? Have you talked about this before?
We probably did.
Okay, so this tool is relevant because if you recall, these buckets, I've just lined them up differently, help us understand how we can intervene. So those deaths that fall into that maternal health and prematurity bucket, which is dominated by low birth weight babies, those are best addressed by addressing mom's health before conception, preconception health, addressing health behaviors across the lifespan. The ones in the maternal care bucket, those are the fetal losses that are slightly larger, the 1,500 gram plus. Those are best addressed by having prenatal care, high-risk referrals for OB care available. Those that fall into the newborn care category, those are the babies that are greater than 1,500 grams at birth, but die sometime in that first month of age. Those often can be reduced by having great perinatal management, neonatal care, and surgery specialized for pediatrics. These are where your NICUs, your neonatal intensive care units, are so very effective. And then that last category, the larger born babies, 1,500 grams, that die after that first month of life, are often best addressed through injury and risk reduction, back to sleep, breastfeeding, injury prevention such as using safe transportation in vehicles. Again, when you look at data for Franklin County, for Columbus, for many large metropolitan areas, the category that is the biggest driver of poor birth outcomes is that top category. It's maternal health and prematurity. So I want to tie this together with that life course perspective. Understanding mom's health before she ever conceives is really critically important in order to reduce or mitigate the impact of poor birth outcomes. If I recall correctly, for Columbus as well, so this is the largest driver of poor birth outcomes. I think the second largest is probably infant health, a sudden unexplained infant death category, as well as safe transportation and breastfeeding. The smallest category is often the area where we put the most attention as healthcare providers, and that's newborn care. We do a very, very good job with medical care delivery to fragile infants and at-risk moms. Not to say we can't always improve, but the greatest areas or opportunities for improvement lie in those other areas. So taking that into context, I want to share with you some examples from experience in Tennessee. Go back with me to 2006, where we had in Tennessee a legislature, and so again, I'm very grateful that there are policymakers who are activated and eager to help understand what are appropriate solutions to address this scourge for the United States. We had a legislature identify infant mortality as a primary issue of focus, and even allocated a modest amount of money, resources for this. We had great statewide data. We had population-based data that helped us understand infant mortality by region. The darker regions in the state represent areas of higher infant mortality. Going from the southwest, that's Shelby County, that's where Memphis is, which was the area with the greatest number of infant deaths and the highest rate, across to Davidson County, which is about in the center of the state, that's Nashville. Hamilton County, down in the southeast, that is where Chattanooga is. So at the state level, what we understood is where poor birth outcomes were happening, and we also understood some of the associated determinants. But we didn't necessarily understand why things were occurring. And the reason I share this is because it is really important that you're addressing this at the local level. At the state level, it appeared when you mapped out use of prenatal care resources, you would see that low-use prenatal care resources were very similar on the map. Prenatal care access and utilization was very low in the southwest, in Shelby County and Memphis in the southwest of the state, and better towards the center of the state, and low also in the southeastern part of the state. And so those dollars that I said the legislature appropriated were to increase access and utilization of prenatal care. But is that necessarily what we needed to do? In 2006, this is when I say the face of infant mortality in Tennessee, and it's so important to understand that we talk about this in numbers. Every one of those numbers is a tragedy to an extended family and community. So every day in 2006, 22 babies were born prematurely. Every 48 hours, an infant died in Shelby County, and we lost 733 infants before their first birthday. In Memphis, our attempt was to address this across the state. This one example I'm going to share with you is from Memphis. there was a nonprofit organization, an early education organization called the First Years Institute. It is now the Urban Institute. And they had been doing a community-based educational campaign around a number of issues, one of which was infant mortality. Educating the community about what is infant mortality and what they could do to reduce their risk, including utilizing prenatal care. We had the benefit of the Early Years Institute having done a survey of the community residents and asked them about their educational campaign. This survey had been done over 2003 to 2006, and what they found is that public awareness of the issue was really quite high. The messages had great uptake. Most people that they surveyed could tell you what infant mortality was, could tell you what they could do to reduce their risk. And unfortunately, most people surveyed themselves had been impacted or knew somebody else who had been impacted. But this is the most helpful question that they asked on that survey. What would you say is the single most important problem facing your local community that is the one that you yourself are most concerned about? And keep in mind that most of these people had been impacted themselves by infant mortality. But infant mortality and health as a category was 7th out of 10 on this survey. The most pressing issue to these community members were crime, education, government, jobs. Not surprising, and probably not unlike many urban areas in the United States. Remember back to what we were saying about a life course perspective. If you are in an area where you are worried about your safety or your family's safety chronically, what impact do you think that has on one's body well before pregnancy, let alone during pregnancy? This was very telling. We learned from this a number of things. One is humility. The other is that we need to partner from a state perspective locally to really understand the why and to help get at local issues that drive poor outcomes. From a state standpoint, we partnered with our county colleagues in Shelby County, Davidson County, and Hamilton County, which were the areas where we had the highest numbers and rates of infant mortality. We co-hired a full-time person, an infant mortality reduction coordinator in each of those 3 areas. That person reported to county government, but had a dotted line supportive relationship with the state. And we created what we called core leadership groups in each of those 3 areas. And when I say we, the framework happened from the state. The work happened locally. So in each county, the core leadership group was representative of, much like the representation on this task force, residents of the communities themselves. We felt very strongly that they needed to have a large representation in these leadership teams. Government entities, because we need to be able to address policies that affect these outcomes. Community agencies, local businesses. Businesses as employers pay for this. Businesses who seek to have other businesses attracted to their community pay for this. Academic institutions, the faith community, which was very strong and an important stakeholder in some counties more so than others. Nonprofit organizations, and I put medical community down at the bottom because they were the smallest representation in this group by design. Again, not saying that clinicians aren't important, of course they are. I am a bit biased on that, but recognizing that medical interventions were not going to address this outcome as much as all of the other stakeholders could. So these core leadership teams worked with their local governments, worked within their communities, and the GOCCC is the state entity that facilitated it. That stands for the Governor's Office of Children's Care Coordination, a unique office created by the governor to help facilitate services to child-serving entities. So it was led locally. I want to emphasize that again. There were some guiding principles that we embraced for this. The first and most important is that the The community owned the change, not the county and not the state. That we agreed to be guided by evidence-based practice when it was available, working to build upon strengths and not just identify deficits. We would be culturally and linguistically competent. We will measure our outcomes. This is not set up as a research study, but it was important to measure our outcomes and know if we were achieving what we set out to achieve. We had to consider sustainability in priority setting. When we said we're going to embark upon a program, we had to be thoughtful about how are we going to fund this in a sustainable way. And then we used a model that has been around for a long time, and that is the REACH model. It's a racial and ethnic approaches to community health. It is, in essence, a capacity-building grassroots model. You take the residents, you build the skills in that resident, that local team. You support them with policy-level change, administrative and legislative when appropriate, and that enables change over a sustainable period of time. So let me speak specifically to the strategies now. We categorize these strategies. I retrospectively categorize these strategies based on Dr. Liu's paper. I think that was probably in some pre-reading on the strategies to reduce poor birth outcomes and particularly eliminate disparities in poor birth outcomes. And one of that first grouping of strategies is enhancing accessibility of healthcare across the lifespan. So several of the strategies that we employed fell into this category because you recall that the state funding was primarily for increasing access to and utilization of prenatal care, so we had to be somewhat creative. We did that by infrastructure grants to academic partners, community health partners, and atypical partners. We embedded centering pregnancy, which is a model of group prenatal care. It's a very effective model in reducing preterm births, particularly so among African American and minority populations. If you're not familiar with that, I encourage you to look it up. Jeanette Ikovics and, I can't remember, Pat, you probably remember the other author of that. But it very effective, 33% reduction in preterm birth, 41% reduction among African American women. So a very effective strategy. We implemented centering pregnancy in our public health clinics in addition to training obstetricians who were interested in doing this practice. We ensured that our Medicaid policy was consistent and paid for this as it should to incentivize providers to use this model of group prenatal care. Why it was effective, or why I believe centering pregnancy is effective, this group model of prenatal care not only enables one to deliver standard prenatal care, the medical care and the education, it also engages support persons. Mom brings along a friend, dad, her mom, other people, and importantly, they do this in a group setting and they coach each other. So it isn't the clinician lecturing the patients, it is the patients educating each other. So they build capacity, they build their own strengths. We implemented Promotores de Salud. It is a very old community-based grassroots support within the Latino community of a community health worker supporting mom during pregnancy and after delivery. Very low cost, high touch, high impact strategies. We also implemented strategies to enhance the family and community systems. The very way that we organized our infant mortality reduction core teams, requiring that we have a large percentage of community residents represented in those teams, allowed the community residents themselves to own the strategies. They function, this is important to note, because again, we had some state dollars to appropriate. We said that if you would like these state dollars, communities, for programs, those programs have to be vetted through these core teams. So it truly did allow the core teams to have the power to prioritize. And we also implemented something called community voice. That S should not be on there. Community voice is a community-based program out of Lynchburg, Virginia, that has been successful, similar to a community health worker model, very low cost, high touch, training any interested party in what it means to be healthy and paying particular attention to supporting healthy birth outcomes. These persons that participate in this training graduate after passing a test, graduate and become these lay health advisors who coach each other in barbershops, in the grocery store, at church. And then there were a number of statewide initiatives. Those are the local ones. We had some state-based initiatives, including implementing statewide fetal and infant mortality review. Tennessee did not have a FEMA program. Ohio does. You have the benefit of having that data. It's important data to understand not just the numbers, but FEMA includes an interview with the mother and family to understand more directly impacts on those outcomes. We implemented a Tennessee initiative for perinatal quality care. This is driven by the clinicians in Tennessee across all child-serving hospitals, and obstetricians, perinatologists, pediatricians, et cetera, that got together and said, how do we ensure that we have common practice across all of these hospitals to specifically improve birth outcomes? Paying attention to things like reducing elective C-sections, for example. We implemented tobacco cessation coaching and counseling in the clinical setting. This is an evidence-based model of tobacco cessation counseling that we implemented in all of our public health clinics, and we trained, again, interested private obstetric providers in this model. It is reimbursable as well, which is really important. And we aligned public and private home visiting resources. Tennessee publicly had 4 different home visiting programs with 4 different models, and we aligned our models and tried to align our outcomes to be measured to support moms prior to, during, and after pregnancy. And finally, invested in support for family planning. Pregnancies that are planned have a better chance of having a good outcome than unintended pregnancies, so supporting family planning and addressing teen pregnancy prevention as well. So this is what's important to know, is once we started implementing this constellation, state and local initiatives, we've had significant impact on infant mortality in Tennessee. So you see, Tennessee compared to the United States has demonstrated a downward trend that we just have not enjoyed historically as a state prior to that. I show the numbers have declined as well, because sometimes rates and numbers are affected by your denominator, so the numbers have declined as well. But this is, I think, what is really compelling, is we're closing the gap. We're closing the racial disparities on poor birth outcomes, and importantly, we're closing it by decreasing infant mortality among African Americans, and not because of upward trends in infant mortality among the Caucasian population. Critical success factors, I think, are here. Understanding the drivers of poor birth outcomes at the macro and micro level. Understanding the why of communities. What happens in your different zip codes in Columbus may not be the same drivers across those zip codes. Having a shared vision with clearly aligned, multifaceted strategies and attainable quick wins. It's hard to keep folks engaged for the long haul, and you know this is a long haul. So identifying some quick wins early beforehand will help to keep people engaged, and applying this over the life course. And then finally, this may seem obvious, but it is really important to assure that you have complete transparency, patience, and shared accountability. Nobody owns infant mortality. Clinicians, pediatricians don't own it. Policymakers don't own it. We all collectively do, and so we need to figure out how we demonstrate that. I'm not going to read the key points. We have gone over these, and you have them in your notes. I am going to ask, though, do we have, how much time do we have? 10, 15 minutes-ish for questions, though. I gave a lot of information.
So do we have any questions? I know it's a lot of information, but a lot of very, very good information and takeaways. Don't take the blank stares as over their head. I think for all of us, absorbing these facts is tremendous. And also, Mike and I were just commenting, it's welcoming to see statistics like you show for Tennessee, because that's a key indicator that it is doable. And for me, big takeaway is you got to focus local, communities, zip codes, but there are communities inside those zip codes, so, I don't want to start off trying to quantify in a numerical, this zip code versus that. It's about the communities, and it's about support at the state level as well. Any questions or observations? Yes, Dr. Long.
Do I? Oh, I'm on. Thank you very much for coming. I'm struck, Dr. Gunn, about what the community said were their biggest issues, and clearly they weren't connected to health and health care. The issue of crime and neighborhood safety, I think, was right at the top, along with education. So did any of your strategies, because the strategies you then talked about were really connected to health and well-being, did any of the strategies that got employed, and it may be not at the state level, but at a more local level or anywhere, address those other key drivers?
Yes, thank you, and a very fair question. So this is where I said we learned a little bit of humility at the state level. The focus of the allocated dollars was declared. It was for prenatal care and increasing access to and utilization of health care resources. So at the state level, those initiatives aligned with that charge. At the local level, though, you're absolutely correct. So in Memphis, which is where that study was from, in Memphis, Shelby County, the core team also engaged law enforcement. And law enforcement, which I don't want to credit solely to the infant mortality reduction initiative, law enforcement had been trying to find new strategies to address crime in Memphis for some period of time. They implemented a strategy which, if memory serves, they labeled Blue Crush. I don't know where that came from. Blue Crush, not long after, but in partnership with some communities in particular that had high rates of recidivism in crime to get at exactly that issue. The other thing that we worked with is recognizing that one has a lower incidence of crime in communities where there are community residents that are actively engaged with one another. So implementing community voice, which is the lay health navigator program, and training neighbors to be neighbors, was another strategy, a very subtle strategy, but another strategy at effectively building community, which would have a downstream impact on reducing crime. There have been some improvements in crime reduction in Memphis, Shelby County. It's still a long way to go there, but that's a great question.
Veronica, congratulations. It's just great to see you again. Wonderful work. You emphasize, and I couldn't agree more, quick wins. Yet it took several years before the infant mortality count or rate began to decline. What were some of those quick wins that you celebrated?
Great. So Dr. Gabby asked about quick wins, which are critically important. And I'll say I am astounded, quite frankly, that we've seen this reduction in infant mortality, which is an important indicator, but usually it's a lagging indicator. I honestly did not expect to see this decline in this period of time. And I think it represents some of those early quick wins. So I think quick wins that we identified for the community, or the communities themselves identified, were process ones. Can we maintain a cohesive group? Can we identify a vision and a strategy towards that vision that we all can support and own different parts of? How do we engage funders in identifying sustainable approaches to this? Some policy quick wins were also important in Memphis, Shelby County. One of the payers would not cover the cost of breast pumps. And this was really frustrating when you're trying to increase breastfeeding for moms, especially among African American community. And you have babies that are born prematurely, and having breast milk really improves their chances of a healthy survival. And so we were able, from a state standpoint, to facilitate that policy change. Those were very small in the scheme of things, but absolutely perceived as quick wins. I think one thing that would be helpful as you all embark on this is identify those ahead of time so when they happen, you can celebrate them. Because sometimes they're hard to see as you go along. Oh, we had our first class of centering pregnancy moms complete a class. That's a win. You had 100%, you had 99% participate through the whole centering pregnancy curriculum.
We're going to have one more question, then we're going to take a break and come right back.
Thank you for being here first. My question is in regards to the community health worker work and also from a funding standpoint. Did Shelby County or does Shelby County receive Healthy Start federal funds, and is the work of the community health workers Medicaid reimbursed?
Oh, good question. So yes, Shelby County does receive Healthy Start dollars which they use for their home visiting programs and for early childhood programs. The community health worker, the lay health navigator, has been initially was state funded and then has subsequently been grant and philanthropic funded. I'll share with you, in switching gears to Milwaukee, Wisconsin now, in a children's hospital setting, we are testing that same model. So Children's Hospital of Wisconsin, it has hired community health navigators and are testing the return on investment for that to actually take it to payers. So we are trying to understand the sustainability of that, and I think we'll be able to demonstrate that without any difficulty.
Okay, so I made a mistake. We're not going to take a break and come back. We are going to, though, engage in an exercise as a result of some of the table setting that's been done by Dr. Gunn. We really appreciate this.
Thank you.
This is very eye-opening, overwhelming, and encouraging news at the same time. Love the conversation around strategies and really pushing home the whole issue that this is about health, total health, over a period of time. This is one of my favorite slides. It's a slide that Dr. James showed us at the last session. I think the conversation that Dr. Gunn has helped us do a deeper dive on around this is that this tip of the iceberg and what's beneath it, the social determinants over a life course and how critical they are. So what we're going to do today with this as a backdrop, Dr. Gunn's conversation, the strategies that have been identified is really now move into our own exploration of these life course social determinants of health, and as a task force and as the audience take a little deeper dive. Over the course of the next hour, what we want to do is expose you to the reality of some of these social determinants in our community. We also want this group to engage in a dialogue that will help us lay the groundwork for achieving our goals overall and goals in reducing the racial disparity. With the group at your table, you'll spend 10 minutes at each poster board station. The posters are turned away from you. They'll be turned around. These stations will give you a sense of the scope of the problem in our community and the link of that problem to infant mortality. We've also included personal stories from real people in our community at each station, which will show how these issues and some others, for instance, transportation, childcare, intertwine and compound each other. These challenges create incredible stress for women and their families in their daily lives. Stress that through this conversation in the last meeting, we are very clear about the impact of that. And I think we've taken stress now and dissected it to a level that it is something real and tangible and not something that you can equate with someone getting on your last nerve, which it's that as well. The good news is that these challenges can be overcome. In fact, many of the stories you will see have positive outcomes for mother and baby. And it's due in part to many of the good programs and services we already have underway. I'm convinced the resources are there. There are things we're going to have to add to those resources, but there's a lot of work already underway in the community. We'll showcase some of these services as we address specific interventions over the course of our remaining meetings. But the purpose of today is to give you a sense of some of the barriers we must overcome in our communities. There's an expert facilitator. I don't know that they realize they are our expert facilitators at each station that will help guide the dialogue and answer questions that you might have. I want to thank each of these facilitators. They are experts from our community. This is another indication of how well resourced we are. Dr. James and Dr. Gabby are critical resources for us, but we have others in this community that can engage and be helpful. Suzanne Coleman Tolbert from COWIC is at one of our tables. We also have Mike McCaman, and Mike, if I butchered your last name, forgive me, from the Franklin County Department of Jobs and Family Services. Isabel Toth from Community Properties of Ohio, and Sergeant Steve Livingston of the Columbus Division of Police. Very glad to see their continued engagement. Mark Mollenkoff from the Mid-Ohio Food Bank, and Steve Vota, my good friend from Other Ventures and Communities, from Learn for Life. So Dr. James and Dr. Gabby have graciously agreed to sort of circulate from table to table. And as you're learning with your group, you'll have a series of questions to consider. You will have someone with your group helping to record your responses, so it's important that you have someone who will report out, because we'll dialogue on this later. So be sure you select your reporter before you get started, so that person is aware that they have to be engaged as well as recording. You will start with the station at your table, and you'll rotate clockwise to the next station. And to allow the members of the public who have joined us to have a similar experience, we have set up duplicate posters in the lobby for you to review and contemplate these same questions and these same issues, and to take notes. We also have worksheets with the questions that we'll consider, and if you're interested, you can complete those. We ask you to, and please return them. So this is a way for us to get real-time dialogue and input, if not dialogue, with you as well. That was a kind of quick overview of the process. I'm going to venture out to say, does anyone have any questions? All right, good stewards of instruction. So we're going to start the gallery walk, but keep in mind our focus is on hunger, housing, safety, education, and employment. I'm sure there are others that you could add to the list, but we'll start with this one. And the staff will monitor the time and notify the group when it's time to rotate. So, with that, let's get started. And I'll call a break about 10 to 5 minutes before we have to come back together. And we're off to the races. Thanks, everyone.